Welcome, everyone. I hope you guys can all hear us and see us. I am Natalia Salcedo, the country director for Glasswing here in El Salvador, specialized in public health and extremely passionate about access to mental health. So thank you all for attending our panel. Our panel is the frontline workers as first responders in mental health, and we really hope to provide you all with a dynamic roundtable conversation exploring how frontline workers, be it teachers or police, public health care providers, through community-based approaches can really improve access to mental health. For those of you just joining in, Glasswing's mission is to address the root causes and consequences of violence and poverty through mental health and education programs that empower youth and communities and really strengthen the public systems. So through cross-sector alliances and evidence-based programming, Glasswing creates opportunities for local change makers to thrive. Just one quick note to our audience is that you will be prompted to fill out a poll as we close out. It's definitely optional, but we encourage you to participate. You can submit your answers on the right side of the screen. So now I'm actually thrilled to have such incredible panelists with us today. So we have Gary, Lauren, and Lena sharing their amazing experiences in community mental health around the world. So to start off, I'd love for each of you to present yourselves, your organization, and a little bit of why you ended up working up in this field. So to start off, I'll move over to Lena.
Hello, I'm Lena Verdelli. I am a clinical psychologist by training, and I'm currently on faculty in the clinical psychology doctoral program at Teachers College, Columbia University. I'm also the founder director of the Global Mental Health Lab there. So our team specializes in the adaptation of psychotherapy packages, psychotherapeutic interventions, for low resource settings. And we adapt them for cultural and contextual relevance, and we test them. And if we find that they are effective, we disseminate them. And I have to say, we couldn't do this work without very strong and long collaborations with community health workers. So I'm very honored to talk about this today.
Thank you, Lena. Gary, let's love to hear from you.
Yeah, hi. Thanks very much for inviting me to this. So I'm a father of this fabulous guy. But what I also am is a psychiatrist who's mostly worked in public health settings and in public policy settings. For the goal of how do we reach whole populations, and so this role of frontline workers as first responders to mental health is their role is everything, and there's so much more we can do to empower and give them the kinds of tools that Lena has been so great, and the whole community in the global mental health world has been so great at packaging and using. And I just want to show one quick illustration of the possibilities here. So I served a bit as the deputy health commissioner here in New York City, and developed something called Thrive NYC, which was based in New York City, but it actually took things I learned from the global South, where the real innovation was happening, in terms of how to do more of the work of mental health in other places, not mental health clinics, but police precincts, school classrooms, job training programs, daycare centers, neighborhood street corners. And we, this map that you see here are actually geocoded dots of areas where we did interventions and we made things available to people where they lived. Each one of those dots across this map of New York City is outside of the mental health system. It's in all these other places. But with the mental health system as a key partner to support these other places to have the skills and do the work. And I'm super inspired by, for example, organizations like Glasswing, which are really supersizing this idea to impact other social outcomes like community violence, and see mental health as not just an end in itself, but a means to other ends when properly positioned deep into communities. So I look forward to talking further about how to do that and how Lauren and Lena are very much a part of doing that, and how we have to grow this as a movement and a new normal globally.
Definitely. We definitely have to grow a movement. Lauren, over to you.
Yeah. So hi, everyone. First of all, I'm so excited to be here and talking about this today. I'm Lauren Magoon. I am the Senior Health Strategy Specialist at Damagi. For those of you who don't know Damagi, it's a social enterprise. We're a tech company who builds scalable, sustainable digital solutions for frontline workers and frontline worker programs. A typical use case is community health workers in lower and middle income countries, but it is used, many of our products are used globally, even in higher income settings. I specifically work with the global strategy team and the research and data teams on how Damagi can support programs such as Gary was describing and Lena develops through technology to scale up to even more places, support their workers through supervision, training, data collection, and even we're exploring early direct-to-client solutions for the people who are working with community-based programs as well. And by way of background, I worked in maternal health for a long time, which has a deep intersectionality with mental health as well, and quality improvement in both healthcare and public health settings.
Yeah, amazing, honestly. I think you guys are even know this way more than I do, but chronic and acute exposure to violence really results in like a widespread trauma that has severe negative consequences, not just for individuals, but for communities and in certain cases for regions as a whole. Despite the high levels of trauma, there are extremely few mental health supports to mitigate its effects in many countries. Mental health care remains very stigmatized and underfunded, and mental health professionals are really in devastatingly short supply. However, I do think there is reason for hope as there are community-based approaches which you guys study, research, and implement that are less resource intensive and that have proven effective in improving mental health. So I would love to have you guys share examples of these experiences in community-based approaches, kind of what has worked and had a great impact, or also we could really learn from lessons learned and what would you have done differently as well. So I'm going to start off with Gary on this one.
Yeah, trauma is a really great example, a sad and tragic example of this truth that we're going to have these intractable social problems that we blame on other things and we let other kinds of divisive politics fester, approaching or taking advantage of as social problems to point to other people who are at fault, rather than realizing that we can repackage things we know and appreciate, like methods of care and support and emotional resilience that we can empower people with by, again, reframing, when I think of that map that I showed, it's sort of like changing the real estate of where the work of mental health happens. And we have a rich evidence base from everything from things that people can do individually for self-care in terms of anxiety and distress reduction, to more over time longitudinal ways that people can help each other in group settings that are familiar to them in the context of their neighborhood, their faith community, methods that are peer-led. One example of that we did in New York City was to equip folks who were formerly incarcerated and trained to be kind of street intermediaries, mediators, in motivational interviewing skills, which made them better violence interrupters, but also gave them an added tool in reaching people who were adversity facing and often trauma facing, with a whole new tool to reach them in that work. So it's this idea of mental health being embedded as a means to the end. How we wake up our systems that are instead given the problem of reducing violence, our criminal justice systems, our other systems, our judicial systems, to wake up that actually we really have to spread the ownership of this issue to other tools and other expertises that eventually put it in the hands of community members themselves.
Agreed. I think it's fundamental to be able to teach those who are in the front lines, right? Like, and in the end, I think it all starts with ourselves, and that's such a key component of bringing mental health to lay workers. It's understanding how to treat others or help others, but also if you don't understand yourself, then it's very hard to treat others properly. Lauren, I'd love to hear a little bit about your experience.
Yeah, no, that's great. And I think building off what both you said, we at Damagi work a lot with community health worker programs and frontline worker programs. And I have to say, I'm actually hopeful that day to day I get to talk to and meet with lots of community-based or task sharing approaches to care that really have, wonderful evidence improving mental health outcomes. And many of them just need to scale and spread more and have funding as well, of course, which is the elephant in the room often in mental health care. We work quite closely with a group called Sangath in India, who also sort of has an affiliated group, Empower at Harvard, who I'm sure Lana and Gary know them well. But seeing how they've been able to approach, providing mental health support to people with moderate to severe depression in India through ASHA workers who are community health workers who come from, not a highly educated background and really have really excellent outcomes, and how they're looking to scale and spread that through both digital tools and also implementation support throughout their work, which I think is promising, hopeful. And that's just one example. We work with them a bit, so I called on them. But there's many other similar approaches, which I just think are, when I first started working in global mental health, it was, you see some of the statistics we may talk about later, which are fairly daunting. And then talking to how much excitement and passion that a lot of both new and established programs have, I think is great. And just in terms of a quick lesson learned, something I learned in a prior role when I was working in maternal health really was the importance of a trauma-informed approach and a sort of a universal precaution of trauma-informed care. I think it's particularly resonant in maternal health, but it carries over into other things as well. And learning how people admittedly sometimes in more clinical settings, are using language that's harmful to folks and even re-traumatizing folks in ways that they don't even intend to. And sometimes I think there's simple, I don't want to say simple, this behavior change is always hard, but not necessarily expensive things you can do to implement trauma-informed approaches within an organization, like across operations, from everyone from the front door, recognizing trauma and trauma-informed care, to actual one-to-one care provision or treatment, whether that's a lay provider or a clinician, is something that takes operational time, but not necessarily a lot of money. And I think more people should be paying more attention to that, and it would improve mental health outcomes. And I think honestly, it helps staff as well, because they'd feel more connected to the people they're working and causing less harm, which they feel that when they're doing it, even if it's not intentional. And specifically around language, I've seen it being very important in maternal health care when people are trying to be supportive and sometimes using language that actually does the opposite with folks.
Yeah, it's amazing because you think you're trying to do something that's good, and it ends up backfiring on you just because you don't know that what you're doing ends up hurting someone, or it ends up reliving an experiences that they've had before. So that's definitely a very important topic. Lena.
Yeah, I was in response to this invitation, I was thinking, reflecting about my trajectory of this work. It's 20 years ago, actually, that I started. And this was for a clinical trial in Uganda with Paul Bolton from Hopkins. And this, we were prepared as we were preparing for the trial, for the adaptation, and training. We are prepared to train mental health workers. We arrived there and we are told that, I'm sorry, the NGO could not spare them, but you'll work with our younger brothers and sisters, community people. And we, of course, thought we should leave, but we stayed. And that was a revelation for me, because they did this work, the psychotherapy, not just they did it well, but also they co-constructed it with us, as Gary said. They led us, in understanding the cultural, contextual relevance, as I mentioned before. But also, initially, I had to shift this thinking that well, if there are no mental health specialists, you have the generalists, right? The community health workers. But now I realize that they bring something more. There are advantages. It's not like, okay, it's substitutes, a poor man's substitute. There are advantages. They have access, they have credibility in ways that we don't have. To give you an idea, we finished this here in a national actually project. I have a collaboration with a Vital program. So I work with student veterans who have this GI Bill and study, in Colombia and many other universities. So we had developed this 3-session engagement strategy, because typically they don't want to go, to the VA when they have struggles and they are very distressed. So we have this 3-session strategy. And I tested with my postdocs, my colleagues, the results were very good, right? Some of them responded because that's what they needed, and others who didn't respond engaged in therapy more. But now we are working with student mentors, other students, for the veterans as well, who get it. And we are doing the qualitative work, and we are finding out that our clients are much more enthusiastic. So there are some advantages there. So this is the big lesson learned for me. As both of you said before, we have tremendous challenges today, so we have to use it, right? The reverse applicability, and Gary has been an architect of that in this city. With friendship benches, I hope you'll talk about that, Gary. It was wonderful. But, between pandemic, right? Between, displacement due to wars, I work now with, the response to Ukraine. There are 84 million forcibly displaced people 6, weeks ago. Now there are 96 million. This is getting worse and worse, and these are getting more protracted. So we have that challenge and the climate crisis challenge. So we cannot afford, to ignore the solution there. Poor and rich countries, we all have low resource settings, and we need this linking between, the places where health is offered and the communities. So we, like with Lauren and Sangath and Gary, we also, by teamworks, under trees and churches and basements in schools, to do this work. What I would have done differently, I would have been, and I'm now trying to do that more, a more forceful advocate in the use of community health workers in, high resource areas. It took us, the field, a while to understand this. And it's not enough to publish the papers and talk to journals, or, we have to be advocates. So we have to learn, on the go advocacy skills for that.
Yes, agreed. I think we all have to be very clear on what we need to advocate for, right? So that the message gets through to who we need it to get through. I know that poor mental health access and care can result in severe and lasting consequences. And from the work and evidence that you all have either generated or know, I would really like you guys to share some of the most shocking statistics that attest to the importance of mental health care for all. And I think it's critical for us to know kind of what works or what the situation is like. Lauren, I'd love for you to start off this.
Yeah, sure. So I kind of alluded to this before, but when I first started working in this field, I was certainly well aware of the challenges of mental health, particularly in lower and middle income countries. But I still think I was shocked by some of the scale of the disconnect between access and need, as well as the lack of funding. So I'm just going to briefly, since you asked for statistics, talk about some of those numbers that really struck me as most compelling. Things like 75% of people with depression in lower to middle income countries receive no treatment at all for it, none. And it's even much higher in some countries where it's nearly non-existent. And just the scale of the number of people with mental health and substance use disorders, I mean, hundreds and hundreds of millions. I think we're up to almost 300 million with depression alone. And it's a problem that's been growing for a long time. I think dating back to 1990, the incidence of mental health disorders have been increasing. And COVID, of course, has not only brought that to light more, but has exacerbated the situation with, numbers increasing in many places in a variety of ways. And the economic cost is huge. I read an estimate, and Lena or Gary, jump in if I say anything incorrect in any of these stats. The economic cost is up to $1 trillion a year globally for mental health disorders, which really is shocking that doesn't get more people up and moving, because that's a lot of money by anyone's account. And sort of despite all that, the funding is extremely low, with only about an average of 2% of health budgets going towards mental health specifically, and even development assistance. It's a fraction of a percentage of development assistance goes to mental health specifically. All these numbers are a little fuzzy. They're how you define them, but it's exceedingly low. That said, I do see in my own work that a number of foundations, at least, are recognizing that this is a bigger problem and starting to think about it. And I think the most compelling way we can sort of push this agenda, in my view, is some of the statistics and just knowledge, and I'll let others follow up more about this, is just how much of a cross-cutting condition mental health disorders are, right? We sort of all know this, I think, at least in the back of our heads, but it's not always as explicitly stated, I don't think. Things like mental health disorders impact most social outcomes that we care about, whether it's educational attainment, livelihoods, incomes, family life, and community dynamics, as well as other clinical outcomes, which is something I think we don't talk about enough, that co-occurring mental health disorders with other things like TB negatively impacts them, with HIV, and in fact, many other clinical conditions. I think you'd probably actually be hard-pressed to find a clinical condition that a co-occurring mental health disorder doesn't negatively harm the other. I can't speak for every single one, but it's certainly a common thing to be co-occurring and negatively impacting bidirectionally. And so just to me, the fact that we could improve mental health and improve all of those other things at the same time, when mental health issues, of course, are deeply problematic in their own right, is... So like all of those things together, to me, is shocking that we haven't done globally more to move the needle on some of these things.
Yeah, it is shocking that we haven't done more, or that more budget isn't assigned to working with mental health because of the consequences it has on so many other indicators.
Right.
Lena, I'd open it up to you.
Yes. Just to elaborate on what Lauren, so clearly, mentioned. So the burden, right? The burden of the disease of depression, for example, is one of the greatest. It's already second, first, depending on what stats you use, but it contributes to huge burden, the disease, right? And the mental disorders start early in life, usually. It's not like cardiovascular disease. It's not like, cancer that typically hits later. And they hit the person during their most productive years. The person and the families, when they build, the personal lives, the community, ties, their occupational and professional future. So they contribute to a lot of burden. And they're not terribly visible. So sometimes it's hard to get, donors' attention to this. The one thing that I wanted to, some piece of good news is amidst the horror of COVID, was that it's the first time perhaps where from the beginning of a disaster, the mental health need and demand, not just need, but demand, was incredibly high, was a priority. It doesn't happen. It's usually like an afterthought in disasters. Not this time. Also, there was another time where whole services and systems of care had to move within, like 3 weeks from in person to online. And, you know, the thing is that if people started talking more about mental health as a result, right? People were affected. It spread so fast, you know. So people are much more aware now about, you know, also the, you know, the burnout issues, whole workforce, etc., etc. So this is a good opportunity to address a problem that has been there all along, but now it has been revealed. And, you know, there is more emphasis on digital, you know, ways, ways, right, using the cell phone, other, you know, community, localized ways of providing this assistance. So I don't know if we have any time. I have some data if we have some time at some point, which we are publishing now. But what strikes me is, you know, we work in Bangladesh with UNHCR, with Rohingya refugees, in Tanzania with Burundian refugees, in Peru with Venezuelan refugees, actually training Venezuelan colleagues to do this work, and now Venezuelan community health workers. And in Lebanon, etc., nothing is getting better. Nothing is getting better. In fact, everything deteriorates in many of these camps, and the patients are improving. So it's very important to show that in these, you know, very difficult circumstances, human beings want to do well. They want the kids to get education, you know. So how to ignite the emotional, you know, immune system, if you wish, you know, of people and communities is really incredibly important, right? A colleague, you know, for health, as Lauren mentioned, health outcomes. Kate Jameson said this famous line, like, there is no pill to make you want to take pills. Like, you have to believe, you know, you have to value your life and have a future orientation. So, yes, it is central.
Thank you, Lena. Gary, I don't know if you would like to share with us a bit of what you know, and you've seen. You're muted.
You're on mute. You're on mute.
I'm.
You're on mute again for some reason. Now it's fine.
Okay. All right. Yeah, I mean, you know, Lauren's point about how inextricably related mental health outcomes are to other social outcomes. They're interdependent, and we can improve mental health outcomes if we act on social conditions, but we can also improve social conditions if we take new approaches, you know, to getting to mental health outcomes, which are not primarily through, often sometimes it's needed, but not primarily through therapist offices, but through other neighborhood-based experience and the sorts of supports that Lena has just really, you know, enumerated her own map of showing can be done in such different settings across the world. The neighborhoods can lead on their mental health, and that's crucial as a social action strategy. And so I want to link that overall point that the data clearly shows being true, that social mental connection. To pull on something Lauren said about why is it shocking that you know, people, you know, policymakers haven't glommed onto that, and Lena's point earlier about the mental health community needing to be better advocates. One reason why the social determinants are so powerful is that there are some kind of social interests in keeping them in place. And so intervening in this social way to do mental health, I have found in building that map in New York City, bumped up against resistance of whatever, whether it was actual power interest, whether it was just cultural habits to turn to more medicalized, authority-based sort of approaches. Whatever it was, there was a backlash to going grassroots. And the political will kind of succumbed to some degree to that backlash. So it really is going to take, as Lena said, a movement, advocacy from the mental health community saying, no, that's the right way to do things. And that's our work to do, is to build that, to socialize this social approach within, the mental health stakeholdership, writ large. The community level gets this right away. It's these other systems that need to hear and see that from professionals saying, no, that's the way to do it. And that's slowly happening in some places more than others. Again, I think COVID nudged everyone to appreciate, gee, most of this work has to happen in communities. And if it doesn't, our communities aren't there to do things we really need to lean on them to do, like be part of combating a pandemic or the environmental collapse that we're in the midst of and so forth. So I say that only because it's been hard to get mental health professionals to see themselves as social advocates, at least in the global north. And acting on social determinants, acting on this kind of social approach requires us, as a global north psychiatrist, requires us to do that. Just get over it and stop saying that, no, that's political, we're clinical. That is a political statement to set up that false dichotomy, rather than just telling truth to power that the science tells us we need a social approach.
Yeah, definitely agree. And so from the work you've done, because you've done so much work in the communities here in New York, did you see, is there something that you could share with us about how working with a certain type of program has led to either increased well-being or reduced costs? Could you share something that might give us an example of how it translates?
Yeah, no, we did a lot of things, from everything from just hosting a learning collaborative. Not expensive intervention, where we brought almost every hospital in New York City together to work together, just using quality improvement methods. How did they universalize screening and connection to care of perinatal depressed women? We saw skyrocket increasing in the screening. And we saw that just doing that project drove an energy and a legitimacy for innovating within these medical centers, considering strategies, and actually Lena got involved in a little bit of this end of things, considering strategies that were of this sort in caring for moms, especially in a more public, funded hospital system that served, higher adversity facing moms, for whom the, brief visit, medical model was really not going to meet the needs of. So even something just like convening, a learning collaborative had an impact. We trained, and I forget what the target was, but I think the goal was, and I believe it was met, I'm not sure, to train half of all our patrol officers in sort of blanking on the de-escalation skills in behavioral emergencies. And one of, we had statistics on that, but one of the to me, the real testimonial statistic was, we had a police captain say to us of a precinct, since we had this training, officer injuries have gone down. And so, it was changing the ecology of practice. And not, in addition to things like, we citywide ceilinged out and started declining the number of runs of police officers for behavioral emergencies in the community. So those things are movable objects with what you're hearing are pretty low-tech, hands-on, and solidarity building measures.
Yeah, agreed. And I think connections also, we've seen through the work we've been doing at Glasswing, that a lot of it is the creation of these connections of whoever's going in to train. If it's a peer-to-peer training, kind of the effects kind of double or triple, right, in terms of the efficiency or importance or impact that is that we can get. Lauren, I'd love to hear a little bit about, I know your research is very into innovative solutions to improve the access. So I'd love for you to give us a few examples of what kind of work you're doing or what you've seen.
Oh yeah, great. Sure. So the work we're doing at Damagi, I think, is trying to address how we can improve access at multiple levels. So how can we both improve existing programs that are evidence-based to scale to either more people or to more sites, right? So sometimes people are still sort of burdened with paper-based systems that they can't, when you go to dozens and dozens of sites, it doesn't work anymore. And also creating the ability through check of creating data collection, which can feed into wonderful quality improvement methods, which is actually my background, Gary. So I've loved hearing you talk about learning collaboratives because I worked on learning collaboratives for many years, probably with some of the same people you did, in fact. And like having data is actually a key part of being able to make some of those changes in those methodologies, right? And also building scalable tools for supervision practices. So a lot of not task sharing approaches or lay-driven approaches to mental health care, a key part of making them work is really having good supportive supervision, right? And competence-based models. So can you have tools to do that as well? So those are sort of common digitalization, I guess, techniques for sort of program spread. We've also started looking at whether we can, and some of this is just early days, and we're iterating and talking to organizations, building tools for those clients and people who may have smartphones, which is certainly by no means everyone today, but in a very forward-looking approach in 10 years, most evidence says most people will have access to one in most places. It'll still never be 100%, but it's growing dramatically, particularly in a lot of countries we work. Is there a way to support people who are in task-sharing approaches to do sort of their homework and their care in, rethinking their thinking patterns or planning behavioral activation techniques on their phone themselves instead of using a paper-based workbook, which is a lot of people use. And we're also looking at chatbots to do quick positive psychology interventions like gratitude, journaling to help people with some self-care and also just basic self-care approaches, but with an eye to working in lower and middle income countries. Because most products out there that Gary or Lena and I might access on our iPhones in New York are geared towards people like us and aren't necessarily culturally relevant or in the language of the people who need it most. So some of the things that we've been looking at Damagi. And then out there in the field, there's lots of people doing amazing stuff with AI and natural language processing and cognitive behavioral therapy and apps like WISA and Wobot. And I think they're coming along going to be very helpful at some point. And hopefully we can spread those to LMICs at some point as well. Because once again, most of those are targeted at a different population than I think we're looking at here in this group. So that's some of the stuff we've been thinking of.
Lena, I'd also love to hear if you could share examples from your research of how we could really bridge the treatment gap. Like, how do we go from being able to offer mental health to more people without having to depend on mental health professionals?
Well, we have to go where people are instead of expecting for, people who are demoralized, right, depressed and don't have a lot of energy and drowning by the demands of their lives, to come to us, to a system that they have some reasons not to trust also. So we have to go to where they are. Right? So all of us have worked, in settings where we go. For example, I was in the mentoring team of this psychiatrist, Karen knows very well, Sidney Hankerson, who now went to Sinai. He has done this very innovative work with going to African American churches, right, with his team of social workers. He got an MHLA actually award the other day. And he, so they bring various mental health, strategies there. They do the case identification in a way that is not stigmatizing. And they engage the people in a way that is very compatible with what they're used to and what makes sense to them. So that's, I think, a good example that is happening in our backyard. But just to underline something that Lauren said before, which is very important, is the importance of continuing education. right? I mean, these things to be done safely for the public and the community health worker, herself, himself, is to have, some clinical oversight for, until the person is trained, until, for difficult cases or, acute and severe cases, right? For cases that, for people who are not doing well after a while. So for referrals, in other words, but also some oversight, quality, improvement. But we also, speaking of, advocacy, we need to advocate for all of us and give voice to the community health worker organizations um, uh, to do, to have a continuing education models where there are, very specific benchmarks of, credentialing, of advancement, opportunities for advancement, right? And opportunities to, to keep people in their over there. I mean, I had in Haiti with Gary, I had this experience. I trained a number of people, and after a year and a half, everybody, moved on to other organizations. So there has to be a serious commitment to retaining this workforce and taking care of the workforce. When they serve the community in times of crisis, they need a lot of support. This is, I think, critical. Without that, I don't think we can have a strong, sustainable workforce, which is, by the way, immune to brain drain, more immune, I should say, to brain drain than, highly trained mental health professionals who may leave the country, the region, for better opportunities.
Mm-hmm. Yeah. Agreed. And I think it's been said before in this conversation and also in general is how would you guys imagine starting off trainings? Because we've realized here in El Salvador that what really works is we really have to start with the individual that we're working with and working on self-care, kind of of self-realization of like, what have I gone through? Where am I? So that if I'm a teacher or if I'm a police officer or if I'm a healthcare provider, that whatever I'm going to do next with who I'm working with, be it students or a patient who's coming in with a critical wound, I will be better equipped to deal with the situation. So I'd like to hear from your perspective, like what kinds of trainings or what kinds of tools would you consider to be fundamental in this aspect of self-care with frontline workers? Gary, I'll open up to you.
Well, there are a lot of tools out there. I can't say that I'm expert on them, but I think I know Lena is, and maybe she can speak to that. But I do just want to pick up on a larger point that she brought up and that you bring up, which is this is a model that works, but it needs an infrastructure to scale and be sustained. And that means everybody's habits have to change. Local government has to realize that its strength is not in hospitalizing people, but in creating the conditions that community organizations are partners and in bringing to bear the sorts of supports they need to do this work, which is bringing local training institutions to step in to be trainers like this, to bring in local health and mental health systems to be coaches and capacity building partners like this. Everybody's got to get new habits, which I've seen live and at scale, they prefer to have than the ones that they have. Psychiatrists really loved advising community members on how to tackle hard things. They reach more people in an hour than they ever would, and people that they otherwise never would. And so it's a lot of rewiring. And the support to this new workforce, right, these frontliners, is really critical. As Lena mentioned, it could be the beginning of a career ladder, but it needs sustained supervision, support, coaching, learning, but also an attitude of co-creation, which has been mentioned a bunch of times. But I can't tell you how often I was illuminated about evidence-based clinical practices when it got community feedback to make more sense. whether it was just language or whether it was, no, the targets are wrong. No, I would do it this way. And so that all of that is new habits and new investments to sustain. And one of the legacies of Thrive was there's actually now an institute at the City University of New York to train community-based organization in task shared skills. And so you need those kinds of infrastructures and investments. They're not horribly expensive for the benefit, but you need that kind of ecosystem. And then just one more thing, and I'll let the others jump in, is this point, and I think Lauren brought it up, is, to embedding the work into other kinds of networks, particularly other ways that neighborhoods are organizing around things, whether it's about income, economic equity or housing fairness or whatever it is that the community is already organizing around. Those are the distribution networks for this kind of work, because they're poised and primed. They got the finger on the pulse of these really intersectional issues. They're the ones to go to. I have decided to really focus on environmental justice organizations, on climate active, climate mobilized infrastructures, because they need this to grow emotional resilience in communities, but they're also primed to own it. And actually, if I can make a shameless plug, I'm trying to work on developing with a whole bunch of organizations globally that are doing this grassroots stuff, climate and mental health, to build a mental health COP, a real global meeting to break into the climate discussion at a global level, the need for these kinds of investments, exactly this kind of socio-emotional support system. And we really need groups in Latin and South America who might, in Central and South America, who might be interested. And I'll stick my email in the chat if anybody wants to reach out specifically on that. We really need to build out that network.
Thank you, Gary. We have 5 minutes, guys, so I don't know if you guys want to share some last remark relating to this point or anything in general that you'd like the audience to hear.
Do we have any questions by our audience or things that they would like clarification?
I asked Sophie, who's leading the conversation, but she said there were no questions on the chat. So yeah, that's why we haven't asked. Lauren, not sure if you want to chime in.
I can reiterate a point Gary made earlier, I think, or expand upon it a bit about the idea of co-designing with the community you're serving. And really, I suspect he mentioned having worked in a learn and collaborative approach. And I have as well. And one of the things that I found was powerful about those is when you bring people from each aspect of the system together, you really can see the whole system much better and where things are falling apart, where things aren't making sense. And putting people together on a team as equals, you really, I've seen the psychiatrists or the neurologists go, oh my gosh, I didn't know that's how it worked when they heard it from a patient or a family member of patients. And I think that's just so critically important. And I think in some contexts, it can be very hard and you need a lot of preparatory work to make that work, because sometimes the highly trained physicians or specialists take some time to get used to listening to other people's voices as equals. I know that sounds kind of mean and harsh, but I have seen it in real life happen many times. And that's obviously not everyone, but preparatory work sometimes can be helpful. And preparatory work sometimes for the participants who are patients and family members coming into a different setting than some of them may be used to. And we actually sometimes would do work on both ends of that in collaboratives to make the sort of robust discussions feasible. And it really actually parallels as I moved into a tech company, which was newer to me. Like user-centered design is very similar. It's a Venn diagram of overlapping things of co-designing patient care and clinical outcomes, as well as designing tech. Like you really want to get what the user needs, what they're how they're going to use it, what they're doing, and it's been a very interesting sort of parallel of like a lot of groups and industries increasingly really talking to the end user and customer or patient and treating them as the arbiter of what needs to be done.
Thanks. Well, I just want to remind everyone that the poll is going to pop up at the end of the conversation. But thank you, Lena, Gary, and Lauren for this amazing time today. I hope our conversations keep moving forward and that we keep being able to build a greater community health work in the region, not only in New York, but in Latin America and hopefully the rest of the world. So it's been great to have you guys today.
Wonderful. Take care.
Thank you, Naji.
Bye, everyone. Have a great time.
Thank you.